welcome to our live training today on episiotomies and forceps and vacuum. Today you are going to learn what the research has to say on these three different options during delivery, what they are, how they work, a little bit about their history, but we're specifically going to focus on evidence-based strategies to reduce your risk of needing these tools or receiving these tools during birth. So first, let's start by talking about episiotomy. So an episiotomy is where a provider makes an incision into the tissue between the vagina and the rectum known as the perineum. I know it sounds really scary. This is something that isn't fun, right, to experience and is definitely like overused. So it's very common. A common narrative that I see is that episiotomy is needed because we think the baby is kind of big or you've been pushing for a long time, right? These aren't reasons to get an episiotomy. And those may be coming from an outdated and old non-evidence-based approach for delivery where episiotomy is overused. So let's talk about the history of episiotomy, evidence-based ways you can reduce your risk, and why that matters. So first, going into the history of episiotomy, in the early 1900s, there was a provider. His name was Dr. Joseph DeLeet. He was a piece of crap, and he created this movement to over-medicalize birth. This was at a time in the country where people were trying to get everyone into profiting hospital establishments to compete with midwives because doctors realized that birth was an untapped market. And so we need to get lots of people to birth in hospitals so we can make lots and lots of money. And they were right. And unfortunately, they found that this was a very easy task. And over time, they learned the more interventions we perform, the more money we can make. It came from a philosophy at the time too, where people believed that women weren't capable of making their own decisions. And this is one of the reasons why physicians were horrified that midwives were performing most of the care, providing most of the care, because they were women. You know, these campaigns were launched to make people feel very scared of birth and to feel like birth is abnormal unless proven otherwise, and that we need all this stuff and all this intervention outside of ourselves in order to give birth. So we launched this campaign against midwives to try to eradicate them as much as they could. And unfortunately, they were very successful. And then try to get everyone into the hospitals. Once everyone was in the hospitals, they decided to launch this routine procedure. Routine interventions, which included drugging the mothers. There are different forms of drugs that were used. Maybe you've heard of twilight sleep. This happened in an area of the country for, a small amount of time, but it did impact quite a lot of people. Even my husband's grandmother experienced birth this way, where she was getting this mix of morphine and scopolamine to put her to sleep during birth, and then they would do episiotomies and forceps. And so everyone would get this. And so all of a sudden, all these physicians are stepping in with outcomes that are much poorer than the outcomes for the midwives at that time, saying birth is a problem and women need to be controlled and we're going to fix it, right? So we're going to fix the problem of birth by intervening. And some of these people, I'm sure were good people who wanted to help women. I think most of the people were pretty sick people who just wanted to control women and unfortunately had a very large influence on birth in not only the United States, but all around the world. So Dr. Joseph DeLeet became very, very popular. Many people know of him as the father of obstetrics, even though his approaches were, not, they were not ethical. They did not actually support birth or improve outcomes. All around the world chose to adopt his method of routine intervening with birth. He even wrote in a medical journal, he wrote that performing routine episiotomies, where we cut the perineum to open the delivery space, restores virginal conditions for women. That is unfortunately part of our history. And it's important to understand the history when we're learning about these tools because the history plays such a big role today in their use. The reason why we still have a non-evidence-based episiotomy rate in the United States, which is around 10 to 15%, and unfortunately in many other countries in the world, the episiotomy rate can go as high as 80%. And that is a product of the history and of the influence of these physicians that were foundational in the way that we see birth and the way that we address birth today. And over time, with new research and evidence coming out, we keep seeing again and again that the midwifery model of care, that the way that the midwives had been doing it the entire time is actually the evidence-based way that leads to better outcomes and that actually saves lives. And I recently did a training on the midwifery model of care. I'm going to release that video this week. Definitely check it out because we went over a lot of really great stuff in that video. So going back to episiotomy, let's talk about why it's important to avoid an episiotomy. So back in the early 1900s, when episiotomy became the norm, suddenly women were really struggling with urinary incontinence, with fecal incontinence, with pain with sex, and other expressions of pelvic floor dysfunction. And pelvic floor dysfunction became normalized. So if you have ever heard of someone, give birth, or from someone who gave birth, say something like, every time I jump on the trampoline, I pee myself. I can't go on a run without a pad because I pee myself. And this narrative that sex is forever painful after you have a baby, all of that is an expression of how we as a culture, because of the history of obstetrics in America and all around the world, have normalized pelvic floor dysfunction as a normal side effect of giving birth. That is not true. Pelvic floor dysfunction is something that absolutely can be prevented. Giving birth doesn't mean sex is going to be painful. I think sex could be better, honestly, after giving birth, and that's a whole topic for another time. It doesn't mean that all these horrible things have to happen, right? But it's important that all of us stop normalizing pelvic floor dysfunction and start doing our best to incorporate more evidence-based strategies to protect our pelvic floor and to address it if any kind of issue were to arise after giving birth. So the idea with an episiotomy is that it makes a clean cut. When we do a clean cut, we're preventing someone from getting a bad tear. That is the logic, and that is what Dr. Joseph DeLay and other physicians that he collaborated with documented. If we make a clean cut, people won't tear. That logic doesn't really make any sense because either way, we're opening into the pelvic floor and into those muscles, but it's actually not true at all that a cleaner cut is better. What we found through research is that tearing naturally is always better than an episiotomy. It's always better to tear naturally. Natural tear, they say, is jagged and hard to sew up, that it maybe will contribute to more issues for women, and that is not true. Episiotomies lead to more tearing, and episiotomies significantly increase the likelihood for pelvic floor dysfunction, and they can be very painful, and sometimes, maybe I'll say often, they are unnecessary. So it's much better to tear naturally because I'll say that, it's very possible, especially as a second-time mom, but even as a first-time mom, it's very possible to not tear at all during birth. It's very possible. But tearing is a natural part of birth that sometimes can happen. But we can really reduce the severity of tearing. Most of the tears that I've seen have been just a little first-degree tear, a tiny little tear somewhere here and there that just heals up super easily on its own. Those deeper tears are very unlikely to happen when we're avoiding episiotomy, when we're not birthing on our back, and when we're pushing in a way that supports physiology and reducing our risk for tearing rather than doing directed pushing, right? So there are lots of things you can do to reduce the risk for tearing. I have a full training on how to reduce your risk for tearing in Module 5 of the Peaceful Birth Essentials course, which is my free course inside the Academy. So you can check that out, and that goes over my 4-step process. I just updated it recently to reveal the process that I reserve only for my private coaching clients. So I think learning more about reducing the risk for tearing can be really empowering. But when it comes to episiotomy specifically, what's important to acknowledge is, especially if we're looking at the history, there was a big moment where things started to change, where finally movement to really illustrate the harms of episiotomy was allowed to be released and published in medical journals. A study was allowed to be conducted. It was very hard to even conduct the study in the first place because no one really wanted to see that episiotomy was harming people. But like once we got that study out, or we were able to conduct that study and release it, we learned that episiotomies actually increase the likelihood for a severe perineal tear by 22 times. That's really significant. So that means that we tear on top of the episiotomy. And that's not something that we want anyone to have to experience, right? And so an episiotomy should only be reserved for a situation if the baby is really in a life or death kind of situation, right? We shouldn't do it just because we think the baby's big. We shouldn't do it just because the baby's been crowding for a while. The evidence-based use of an episiotomy would be to perform it if for some reason the baby is suddenly in distress and they need to be born right now. That is an evidence-based reason and an ACOG supported reason to perform an episiotomy, not a suspected big baby, not because the baby's been crowding for a while, or some of the other reasons that I hear providers talk about as being a valid reason to perform an episiotomy. So what is the evidence-based rate of an episiotomy? The evidence-based rate is 1. So that means 1 of the time it is evidence-based to perform an episiotomy. So that is very, very low. A provider who performs episiotomies in an evidence-based way, if you were to ask them what their episiotomy rate is or what their stance on is for episiotomy, they will probably say something like, oh my gosh, I've only performed a handful of those in my whole career, right? Or I can count on my hands like how many episiotomies I've performed in my whole career. That is an evidence-based answer. So I recommend, before you get into a situation where you're giving birth with someone who perhaps has a high episiotomy rate, to ask first, what is your episiotomy rate? If you don't want to ask, or if maybe your provider doesn't know their rate, you could just say, I want to do everything I can to reduce the risk for episiotomy while I'm giving birth. What are some ways I can reduce that risk? Or how often are episiotomies even needed? And if your provider says something like, well, you know, episiotomies sometimes are needed, sometimes you just have to cut an episiotomy, that's not a very encouraging answer, right? So we want to get an answer from a provider that's more evidence-based. If they don't give you a very encouraging answer, it's probably ideal to find a new provider if you can. Some people are more limited in the kind of care providers that they can access, and so it's harder for them to access different providers, in which case it's really important that we incorporate evidence-based strategies to reduce the risk of episiotomy with that provider, and we'll get into that in a moment. But first, understanding if they have a high rate or not is important. So that's number one answer that they could give. Another answer that they could give could be something like, oh, you know, I barely even have to do those. It's so rare that those are even needed. I reserve those for emergency situations only. That is a evidence-supported answer, in which case I still think some of those evidence-based strategies to avoid tearing is important for sure, but specific things for episiotomy like provider hands off may not matter as much with a provider with a low episiotomy rate. So when we're making choices about our birth, if we want provider hands-on versus off, which I'll talk about, if we want to be in this position or that position, right, all these different choices, understanding what our specific risk is with that individual provider is really important. And this is why my coaching program can be so helpful, because we make a customized advocacy plan for you rather than going in with information and hoping for the best. It's much better to be very deliberate in our choices around our providers. So I take everyone through a provider audit so we can get clear on like where your provider is on all these things, and then we can incorporate evidence-based strategies to reduce the risk of those things, navigate those certain things, if it's cesarean, if it's big baby bias, if it's episiotomy, and how to avoid that. So going back to episiotomy, let's talk about some evidence-based strategies that you can use to help you to reduce your risk for episiotomy. Oh, and actually, since I was talking about the program, I recommend grabbing that link now and having it in your browser so that you can book a free birth breakthrough session. And on there, I'll clarify the steps needed for you to feel confident and prepared for birth. So we'll map out kind of a customized plan for what's needed for you, and also explore how I can support you. So click that link, and then let's get into those evidence-based strategies. So number one would be to birth in an upright position. Birthing in hands and knees or a standing position reduces the risk for tearing and also reduces the risk for episiotomy. Research has found that when your provider has access to your perineum, that increases the likelihood for you to get an episiotomy significantly. So simply just not giving them access reduces that risk. Being on your back increases the risk for your provider to perform an episiotomy just because they have more access. And potentially also because it might take the baby a little bit longer to come through, or being on your back can also, let's see, how would I put this? It increases the likelihood for having a cesarean because it's putting pressure on a blood vessel that runs under the uterus. So you could argue that being on your back also can create a possibility for the baby to get distressed because they're not getting the same kind of oxygen access, right, that they would be if you were in a different position where we aren't compressing on that blood vessel. So avoiding being on the back to support baby and being well oxygenated to avoid an urgent situation is important, or to reduce that risk, and then also to reduce at provider access. And this is obviously more important with a provider who has a higher episiotomy rate compared to a provider who doesn't. The next tool would be provider hands off versus provider hands on. So provider hands on means that your provider is touching the perineum, is touching the baby as the baby is coming out. So your baby will come to crown and the provider will put their hands on the baby's head, on your perineum. They might perform certain maneuvers, sometimes pushing the head down as it comes out, sometimes putting pressure on the perineum. There are lots of different maneuvers providers can perform. Some of these are outdated and not very evidence supported. And the idea is if we're touching your body, we're reducing your risk for tearing. But what we've actually found is that when the provider is hands-on, your risk for tearing significantly increases due to the higher likelihood that your provider will give you an episiotomy. So an evidence-supported way to reduce your risk for a severe perineal tear and an episiotomy is to choose provider hands off instead of provider hands on. Provider hands off means that your provider is there. This is also known as provider hands poised. They're poised. They're there. They can step in if needed. If the baby's in distress, if the cord is around the baby's neck and needs to be relieved, if there are signs that the shoulders are stuck, those are all reasons why someone might need to step in and encourage the baby to come out by doing different maneuvers. And some of those maneuvers can be life-saving, especially in the case where the shoulders are stuck. That's also a case where potentially episiotomy may be indicated, right, in an emergent situation, not because we're suspecting the baby is big or something like that, but a true emergency is when episiotomy might be indicated. A provider can safely assess in any position you're at, especially if they're willing to get down and look up if they need to, or get in different positions to see what's going on, and then they can step in if needed. Your baby could come out into your provider's open hands. They could come out into your partner's open hands or your mother's open hands. They could come out into your open hands. It's very, very rare that a baby actually needs to be pulled, where we pull on the baby's head to try to encourage the baby to come out, or manually rotated where the provider will turn the baby's head. It's very, very rare that any of that is actually needed. And so provider hands poised, stepping in if needed, is a safe and evidence-supported choice that reduces your risk for episiotomy and reduces your risk for severe tearing. This, once again, is more important if your provider has a high episiotomy rate. Next, let's talk about our other one. Let's see. We talked about positions. We talked about provider hands off. So the next one would be to write on your birth plan that you decline an episiotomy. I don't believe that we have research on reducing episiotomy risk specifically for birth plans, but we do have research that shows that birth plans can improve outcomes and reduce interventions. Having a birth plan that specifically illustrates that you are declining an episiotomy is a really great way to reduce that risk. If the case comes up or a situation comes up where episiotomy is the correct move, which once again is very rare, especially if we're staying off of our back and things like that, then in that case, the provider should say, I would like to perform an episiotomy. This is an emergency. Can I do that? No one should perform an episiotomy without your consent. So the purpose of the birth plan is not to illustrate how things will go. It's just to reduce your risk of being offered an intervention that may be routine to a certain provider. And that might be important if you have a rotation of providers. Maybe some of them have a higher episiotomy rate than others, right? Like if we're in that situation, it might be more important to indicate I decline on the birth plan. And the next step would be advocacy specifically. So learning about advocacy, this is something that I teach in my coaching program. I'll give you a few tips now for reducing episiotomy specifically. One would be to interview the nurse right when you get there. So I would have your doula or support person bring your birth plan to the nurse and show the nurse and say, hey nurse, here's my name and here's the birth plan. Would you go over this with me really quick? Go over it with the nurse. Show the nurse what your steps are to reduce tear risk. I'm declining perineal massage, or I consent to perineal massage. I'm birthing in whatever position I choose. I want hands off, or I want hands on, whatever the things are, and I decline episiotomy. Make sure the nurse knows what all of your choices are beforehand. So the nurse can help you with advocating, and so you can understand if your nurse is a good fit for you or not. Because if the nurse says, oh, we don't do hands off around here, episiotomies sometimes need to happen, or that's really harsh language, sometimes we have to use an episiotomy, you know what I mean? Like if they're kind of giving you some feedback that illustrates that they are not maybe the best fit to support the kind of birth that you want, maybe they're not as supportive of your choices, okay, that's really good to know. Thanks for letting me know that. So I would just say, okay, cool, thanks for letting me know. Thanks for sharing your thoughts. Bye. And when they leave the room, I would go out to the charge nurse, or maybe when they're in there like doing something with mom, maybe send doula out to talk to the charge nurse, and I would just say, hey charge nurse, the nurse that we were assigned to just doesn't really feel like the best fit. We really want to have someone who can support us with birthing whatever position we choose. We really want provider hands off, or whatever the choices that this nurse was kind of snarky about. Was it okay if we get a new nurse? And I would just ask, you don't have to give a big speech about it. You could also just say it doesn't feel like a good fit. Could we have a different nurse? And now you have someone who is a better fit for you, who's aligned with your birth plan, and who can support you better with advocacy in the moment. In the moment, if a provider walks in and says, time to get on your back, and we have this like table of instruments next to you and you're on your back, like that's a very vulnerable position with a higher likelihood for episiotomy if scissors are right there and you're on your back and you can't see anything, right? And so if we have a nurse that knows that you really don't want to be in that position, and provider comes in and says, time to do this thing, and maybe partner says, oh no, we're staying in this position, and the provider kind of has some like unpleasant feedback about that, like, no, you have to be on your back, or they aren't very supportive, the nurse can help, a little bit. The nurse can help with advocacy. So we want to find a nurse that can support you with that. Nurses can help kind of bridge that gap between provider and patient, especially in moments when you're feeling overwhelmed. We can't rely on nurses 100% because they also have a job to do. They want to be able to have a positive collaboration, co-working dynamic with providers, obviously. So it's important that we have independent advocacy as well, which means you really learn about advocacy. So you understand advocacy tools your partner or support people do. And I also recommend, if you can, to have a doula. Doulas are evidence-supported ways to reduce your likelihood for experiencing different kinds of interventions during birth, which is really great. So they can reduce the risk for cesarean, they can reduce the risk for operative deliveries, meaning forceps or vacuum, reduce the risk for episiotomy, reduce the risk for pain medications. So hiring a doula who's trained in advocacy, who's independent from the hospital, is great because they can really help you avoid being in that more vulnerable position where those tools are easily accessed. I will also teach just one more advocacy tool, and this one would be for the partners. So if at any point you as the partner feel funny about what's going on, if you notice the provider pick up scissors or pick up a tool and you're not sure what's going on or why they're doing that, just say something. So I would just vocalize everything you see the provider doing. Oh, I see you're picking up scissors. What are you going to do with those? Right? Oh, I see you're picking up an instrument. What's that for? Even if you already know that's forceps, for example. It's important that you as the partner just vocalize whatever you see to help support informed consent being intact. Informed consent means that both people, right, the mother and the partner, understand the risks, benefits, and alternatives to the options available. and they understand that they can say no. As a partner or support person, you can support informed consent in being intact simply by supporting the mom and remembering that she can say no, and vocalizing if you see something happening, perhaps without the mom's consent. Provider comes in and just goes to do a cervical check when you're pushing without asking first, right? That's not informed consent. That's actually obstetric abuse. A provider performing an episiotomy using forceps or tools that we're going to talk about here soon without your consent. Those are all those are all examples, that's how I'll say that, of obstetric abuse. Obstetric abuse is not okay. It is something that you absolutely can avoid, and having a good provider that you trust is important. Having a good team, interviewing your nurse, so you have a good nurse, having support people who are educated on birth, and having a good birth plan. All of these things are really great ways to reduce that risk. I would also be vulnerable with your provider, and you can tell them, I'm really afraid that something will happen to me without my consent. That's something I'm worried about. How do you go about informed consent? What if I needed an episiotomy? If it was an emergency situation, how would you communicate with me? What would that look like? Really asking these questions and understanding how that goes beforehand is really great, because if we discover that providers maybe aren't really honoring informed consent that much in the way you're receiving care in pregnancy, if you can change providers, I think it's a really great tool to use to support you in having a more positive birth with informed consent being part of your care, rather than you having to kind of work more to kind of protect informed consent, just by having a provider who already practices with informed consent intact. And this takes me to my last evidence-supported step to reduce your risk for episiotomy, which would be to hire a midwife. Midwives around the board, and all the research that we have, we found that they significantly reduce the likelihood of getting a severe perineal tear and reduce the likelihood for episiotomy. So simply being with a provider whose training is rooted in supporting physiology, in perceiving birth as normal unless proven otherwise, reduces your risk for interventions, compared to being in a model of care where the training and philosophy is simply different, where obstetricians are trained to view birth as something that is abnormal unless proven otherwise, and to look for pathology and to treat pathology, right? So in that model of care, you already have a higher likelihood for episiotomy and for other interventions, but obviously your unique provider plays a really big role in this. And we do have research that shows that your chosen provider impacts your risk for tearing significantly. So we shouldn't just kind of go with the flow. Okay, I found this provider, whatever, and I'm just gonna do whatever they say. It's much better to assess the different providers, assess your options, and make a choice that feels right to you. And some people have lots of options and some people don't have as many. But either way, we want to make sure that you're being deliberate as you move forward, which means I'm finding the provider with the lowest episiotomy rate who I feel the best with first. And if I can't find that ideal provider, I'm going to find the best one out of the ones I have. And then from there, we're going to incorporate those evidence-based strategies as much as we can to reduce that risk with that person. So that concludes our lesson today on episiotomy. Next, let's move into forceps and vacuum. So forceps look like salad tongs. They go on the side of the baby's head. So it's basically like a long tool that goes on each side of the baby's head. They're kind of have this round curve to them on each side, and they go here and then they can pull on the baby. And so there's a few different benefits to forceps specifically in comparison to vacuum, which we'll talk about here soon. With forceps, they can guide the baby out by applying some pressure and pulling on the baby to help encourage them to come out in an emergency situation. This might allow someone to have a vaginal birth instead of a cesarean. And there are many benefits to having a vaginal birth compared to a cesarean birth. So that is a huge benefit to forceps. Forceps also can be life-saving in the case where a baby is really truly in distress and needs to come out right away, right? Forceps can be really helpful. So those are two main benefits that are important to acknowledge around forceps. Forceps, however, came into play in the early 1900s and were misused. So they weren't used as life-saving tools when there was a medical indication or tools to help someone prevent a cesarean. They were tools that were used routinely, which means everyone gets this tool. And what we found over time through research is that when everyone just routinely gets interventions, it does not improve outcomes. Interventions, especially interventions that have significant risk, like forceps vacuum and episiotomy, should only be performed if there's a clear medical indication, and that medical indication is up to date with evidence, right? Because it used to be an indication to do forceps and vacuum just because you're pregnant or because you're giving birth or because you're having a big baby, then we should routinely do that, right? And now we're seeing that we only should do that if we're in an emergency situation. Right, it shouldn't be routine. When routine forceps were implemented, that really increased the likelihood of much more poor outcomes for babies. Now they are done far less often. Vacuum, it kind of took over and makes up for the majority of operative or assisted deliveries. Forceps, some people consider to be a dying art because some providers don't use forceps very much. They may be not learning as much about forceps because there's this preference around vacuum. Some providers are still very skilled with forceps, and that's the way that they like to support babies in coming out. Others are more comfortable with vacuum. So the provider that you have also plays a role in whether forceps or vacuum will be used in that kind of more emergent situation. Some providers are more comfortable with one or the other. Some providers could do both. Risks next to forceps are that they can increase the likelihood for trauma to the baby's head. So one is the swelling to the baby's head, or cephalohematoma. This is something that can be reduced, so it's not typically urgent in the moment. It is something that can get better, but it is a risk to be aware of. There's also a risk of a mark being left by the forceps on the baby's head, though that often resolves. There is also a risk for shoulder dystocia. So if we're pulling on the baby before the baby is ready, what can happen is that the shoulders can get a little stuck because the baby goes through movements to go through the pelvis. When we grab the baby's head and we pull, we kind of rob them of the opportunity to get to do those movements to go through the pelvis. And I will say that on that note, a benefit to forceps compared to vacuum is that forceps can turn a baby if needed. So if the baby is struggling with their position, someone's been pushing for a long time, or if the baby is very, very low, we should not do forceps when baby is up high, but when baby is very, very low, almost right at pushing, but they're just kind of struggling with a little bit of a positioning thing, we should probably first try other forms of supporting baby's position, like changing the maternal position. But if all else fails and we're looking at a cesarean, forceps are an option that we can talk about to encourage the likelihood of baby to turn and get in a more optimal position for birth and then be guided out. But it just depends if baby's in the right place for that to be a safe choice. Bone and skull fractures are rare but can happen. Internal bleeding, so there is a risk for internal bleeding for baby from forceps. Seizures and brain damage are also rare but possible risks. And then the last is that the procedure may not work and a cesarean may be needed. So the risks to the mother or birth parent for forceps include pelvic floor dysfunction and urinary incontinence, pain with sex, an increase in the risk for episiotomy, increase in the risk for vaginal tearing, increased experience of pain during the procedure, and feelings of distress or trauma. So those are the risks to forceps. Next, let's talk a little bit about vacuum. So the benefits to vacuum are that they may have a decreased risk of maternal trauma compared to forceps. So forceps can really increase the likelihood of a severe perineal tear for the mama. Vacuum still does increase the risk for tearing, but it's lower with vacuum. So it may be safer for the mom to use vacuum. It might expedite delivery in the presence of an emergency, right? Just like forceps. It also allows you to have a vaginal birth compared to a cesarean birth, right? And then you may feel some relief that this long labor is over and a cesarean is avoided. So both the forceps and the vacuum come with that benefit that we can help you, have the baby and not have to have a cesarean. So those are great benefits. The risks are that, number one, there's feelings of distress or trauma that can happen sometimes with vacuum, especially because with the vacuum, it's this suction cup that is placed on the baby's head. It's plastic or silicone, and then they pull with the vacuum. And so it applies suction to pull and guide the baby out. And so that can sometimes be an intense experience. It can increase the experience of pain. It does increase the likelihood for postpartum urine retention or bladder distension immediately following birth. It increases the likelihood for pelvic floor dysfunction. It increases the likelihood for a pain with sex in the future. And there's an increase in the risk for vaginal tearing. So those are the main ones for the mother to be aware of. The risks to the baby include trauma to the tissues around the baby's face, forehead, head, even their eyes or shoulders. There is a likelihood for broken blood vessels over the baby's eyes. The procedure may not work and a cesarean may be needed. There have been reports of fatal trauma to the newborn. So a subgaleal hemorrhage, or an accumulation of blood between the skull and the skin over the baby's head. That can happen as well, and that reduces and resolves typically over time. Swelling to the baby's head, the cephalohematoma, which we talked about with the forceps, and facial nerve palsies. So there are significant risks to be aware of with the forceps and the vacuum. And there are also very reasonable benefits. The risks are very low, but they are still valid risks to consider. So let's talk about what some evidence-based tools are that you can implement to reduce the likelihood of having forceps or vacuum. And once again, I have notes on this because I wanted to pull up what evidence-based birth has to say. Okay, there was a couple that were specifically different from episiotomy. So the first evidence-supported way to reduce the risk for forceps and vacuum would be to birth in an upright position, like we talked about with the episiotomy. So if you're birthing in an upright position, it opens the pelvis, it allows fetal descent using gravity. That can support your pushing face being smoother, and also we can reduce the likelihood for baby being in distress, leading to the need for forceps and vacuum. Because when baby is in distress, that's when we're considering forceps and vacuum. So when we're not putting pressure on that blood vessel that runs under the uterus, we can reduce the likelihood of baby needing assistance in the first place, right? So that means hands and knees, standing. Those positions are really great to push in. They reduce the risk for perineal trauma. Even lying on your side is better than being on your back. But upright positions like this, hands and knees, and standing, also sitting, like a birth stool. There's in hospitals, they have sometimes an inflatable C-shaped seat called a cub. You could push there. Pushing does increase the likelihood, pushing in a sitting position specifically, does increase the likelihood for severe perineal tear. Same with squatting, because they're putting a lot of pressure on the perineum. And it's good to change positions around frequently. So maybe you can push in lots of different positions. Resting on your side if you're tired, not on your back during pushing. So the next one would be extended pushing times. So I did just do a training not too long ago on the difference between doing pushing immediately when you're 10 centimeters dilated compared to laboring down, which means we're waiting. Laboring down essentially means that we confirm the baby's 10 centimeters, but you're not getting the urge to push. So we're just going to wait a little bit and allow your baby to descend more into the vaginal canal with the contractions and with the help of your uterus. And so when we're choosing laboring down, we're getting some of these benefits of reducing the risk for forceps and vacuum and also reducing the risk for tearing. So laboring down is an evidence-supported way to reduce those risks. And there are other risks and benefits to laboring down. So I recommend checking out my video on laboring down. You can find it on YouTube. You can also find it in the live training section in the community of the Peaceful Birth Academy. And you could kind of learn what all the research and evidence has to say on laboring down. Most of the research we have on laboring down involves moms who have an epidural, because when you're in a normal physiologic birth where you don't have medicines, when the baby's head goes down nice and low and you feel the pressure of baby's head, you're much more likely to push spontaneously because you're getting all of this feedback from the pressure of the baby's head on the cervix and low part of the uterus in the vagina, sending signals to the brain to trigger more consistent contractions and giving you this urge to push spontaneously. That can sometimes not happen with an unmedicated birth, usually if there's a positioning challenge, but most of the time moms will just get the urge to push and just start pushing when they're ready, when their baby is in the right position in an unmedicated birth. But I have seen laboring down happen in an unmedicated birth, and in that case, the mom just didn't have the urge to push. A big study that came out in 2025 on laboring down involved 84%, I believe, of the people in that study did have an epidural, which means that the rest did not have an epidural. So we do have a little bit of research on moms who don't have an epidural. Most of it is with it. With the epidural, it's a really great option to consider because you might not get that urge to push because we're not getting that same feedback loop because we don't have the feeling. So with an epidural, you might feel pressure and be ready to push, or we might do a cervical exam and confirm the baby is a low station, meaning probably +1 or +2, and is ready to start pushing. But if baby still is at a high station and you're not feeling the urge to push, you don't have to start pushing routinely. You can choose to wait. And what we found is that waiting is an evidence-supported way to reduce the likelihood for a forceps and vacuum and for tearing. So go check out that video to learn more on what the research has to say on that. The next would be intermittent monitoring versus continuous monitoring. So another evidence-based way to reduce your risk for forceps and vacuum is to choose intermittent monitoring instead of continuous monitoring. This is only possible if you don't have an epidural or Pitocin or other medications in your system. We don't have a lot of research on some specific different medications. So, some providers will say it's okay, for example, to have a little bit of opioids in labor and still do intermittent monitoring, or to be continuously monitored with Pitocin for a few hours and then we can take you off the continuous monitor when we turn off the Pitocin. So every provider is a little different. I've seen a mix in the recommendations for this. So in general though, evidence-based birth says that intermittent monitoring is a safe and evidence-based option for low-risk moms. Continuous monitoring should be reserved for high-risk people or people with medications in their system that increases the likelihood for a baby suddenly not doing well. So we need to monitor baby closer, which makes sense. Intermittent monitoring is where someone is using a Doppler to monitor you and your baby, right, all throughout labor. So they're using a Doppler to monitor your baby all throughout labor, not to monitor you, but you monitor your baby. So with that, what that looks like is that usually at the end of a contraction, about every 30 minutes, sometimes every 15, when you're pushing, it's closer together, depending on the provider and how they do it. They'll put the Doppler to your belly and they'll listen to the baby's heart rate. And so they'll see how the heart rate experiences that contraction and then how the heart rate recovers. So it's normal for your baby's heart rate to have variation during labor, which means your baby's heart rate goes from 110 to 160 all throughout labor in some kind of variation. So your baby chooses a baseline. Maybe their baseline is 130. And let's say you're getting close to pushing or you're pushing. Maybe you have a contraction and then the baby's heart rate goes down a little bit. And then it goes back to normal after the contraction. That is normal variability. There are normal variations in the baby's heart rate. We just want to make sure the baby's heart rate doesn't go down too far or that it doesn't take too long to come back up. And if providers start to see that, that might indicate the baby isn't doing well. If that ever were to happen, getting in a hands and knees position sometimes can resolve if the heart rate isn't doing well. There are other ways to support if the heart rate isn't doing well that it's like a whole conversation. But if you join my coaching program, that's something you'll learn about, and we can have a plan for how to address that if that were to happen in labor. Hands and knees is a really great choice though to begin with. So with intermittent monitoring, we're checking consistently right all throughout labor to make sure baby's heart rate is doing well and they're recovering from contractions well. Continuous monitoring means we're monitoring you and your baby all throughout labor. So there are two little circles. They look like little hockey pucks, and one goes on the top of your belly to measure your contractions. The other one goes on the bottom part of your belly to listen to your baby's heart rate. And there are straps that wrap around your belly. There are wireless ones and there are wired ones. So some of them come with the wires that connect you to monitors, which means you can't move very far, and that can feel kind of challenging. Other ones are wireless, you can move around, and there are some hospitals that have some that are even waterproof, which is awesome. So you can even get in the water with them. Sometimes the waterproof ones or the wireless ones aren't working. Sometimes they're only available in certain rooms that are taken, right? So they're not always accessible to everyone. But either way, whether you're being monitored continuously with the wired or the wireless, or you're being monitored continuously with internal monitors, which are monitors that connect to the baby's head and connect to your uterus. And that's something that I could talk about later. Maybe I'll do a training on continuous monitoring to kind of learn more about that. Either way, no matter what option you're choosing for continuous monitoring, it still increases your likelihood for both cesarean and forceps and vacuum. And the reason why is because if we're listening to everything all throughout labor, we enter the shade of gray, where liability can sometimes take over and cause providers to make choices that might actually not be the right choice. So since the baby has this normal variation, the heart rate can fluctuate quite a bit. One provider might look at what's going on the monitor and see a normal variation of fluctuation, and they might say, that's a problem. We're going to have to fix that. We're going to have to do a cesarean. We're going to have to talk about forceps or vacuum. Another provider might see the exact same thing and say, that looks like a normal variation of baby's heart rate, is fine. So unfortunately, there isn't any kind of rule around if it does this, we do this. It's more up to provider interpretation. And since there are many shades of gray in obstetrics, and since you have 18 years to sue a provider, and the Western medical model is very liability oriented, the providers typically lean towards protecting liability, which means we're doing forceps vacuum or cesarean, we're going to act on it rather than maybe exploring other options or reconsidering certain variations maybe as normal, being willing to see that. So research has found that continuous monitoring increases your likelihood for forceps and vacuum and increases your likelihood for cesarean without improving outcomes for babies. So it doesn't decrease cerebral palsy, it doesn't decrease the risk for NICU admission, for low APGAR scores, all those things that we'd be worried about with babies. But it does increase your likelihood for cesarean and increase the likelihood for forceps and vacuum. There is one study that found one slight increase in a risk for babies. This is the only one that they found. And it was a slight increase in the risk for a newborn seizure if you did intermittent monitoring versus continuous. But what we found, what evidence-based birth says, is that one, we don't know what the long-term implications are of a newborn seizure, and the risk increase is very low. It's about 0.15% to about 0.3%, around there. So it's a very slight increase in the risk for a newborn seizure. We don't know those long-term implications. We don't know if it's important to prevent those or not, or how important it is. But evidence-based birth says that you would have to continuously monitor 667 people, and out of all of those people, 69 of them would have an unnecessary cesarean to prevent one newborn seizure. So that's kind of what the numbers look like, and when we're kind of weighing the difference, right, between those risks and benefits. So that concludes our lesson today on forceps, vacuum, and episiotomy. I'll just share briefly that all of these tools are tools that should be reserved for emergency situations only with your informed consent, which means no one should just perform one of these procedures without your consent. And it's important that you understand what all the risks and benefits are of these beforehand, and then you have a conversation with your provider about, okay, if we were to potentially need forceps or vacuum or episiotomy, if there was an emergency, what would that look like, and how can my informed consent be intact, so you understand kind of how to navigate that situation with the provider and what to expect in that situation. And it's important to also have support people in your place who are well educated, who can advocate and know how to protect informed consent in that moment, meaning they're vocalizing what they see, they're reminding you that you can say no, they're asking questions. Even in an emergency situation, it is obstetric abuse to use a tool without someone's consent. So consent is absolutely important. Thank you so much for being here with me. Remember to book your free birth breakthrough session with me. The link is in the chat. And on that call, I'll clarify the steps needed for you to go into birth feeling confident and prepared, and then also explore how I can support you in the coaching program.